and today I'd like to talk to you about a patient who was under our care earlier this year with some extremely complex mental health and social needs, and just take you through the multidisciplinary team journey in planning and providing the care in order to meet those complex needs. Next slide, please. So, the story of Natalie. Natalie was a 36-year-old pregnant lady. Oh, sorry, before I start, I'm happy to take questions throughout, but there will be a session part at the end where you can ask me questions. But if you need to raise your hand and ask anything going through, then I'm more than happy to stop and do that. So apologies for that. Sorry, I should have said that in the introduction. So Natalie was a 36-year-old pregnant lady. She had a diagnosis of schizoaffective disorder, and she was detained at Berrywood under Section 20 of the Mental Health Act. Oh, sorry, I can hear someone. I don't know if everybody would mind putting their microphones on mute, please. Thank you. So Natalie had multiple admissions throughout her life to psychiatric units, and she'd had a deteriorating picture of mental health. She was paranoid and delusional and had verbal and physical aggressive behaviours towards staff and members of the public. On this particular admission to Berrywood was a result of a psychotic episode where Natalie had an asthma attack and was being treated in the A&E department of Northampton General, and she physically assaulted a staff nurse that was providing care to her, which resulted in her arrest, having to be restrained by 5 police officers and then eventually sectioned and taken to Berrywood. During that period, she did become stable and was permitted ward leave. However, on one of those ward leave episodes, she was using illicit substances, and she actually became pregnant during the ward leave. Then her mental health deteriorated again. Part of Natalie's delusional beliefs and thoughts really centred around 2 particular characters, John and Jim, who in Natalie's mind were the perpetrators of physical and sexual assaults towards her. And she believed that they were very much present in her everyday life, and were recruiting staff members in the ward area to become part of what she called the tribe. And because of this, she had very, very difficult interactions with some of the staff members trying to provide care. Natalie had a very transient lifestyle, moved around the country. She was a victim of abuse, domestic abuse, as I said, history of long-standing illicit drug use, and she had been homeless and street working. It was quite difficult to form a full picture of Natalie's lifestyle because of that transient lifestyle that she'd had. But we were aware that she had 3 children who had all been removed from her care. Again, it was very difficult to establish a true picture of what had gone because of the different areas. Although it was staff had tried to gather information, it was quite difficult to get the true facts around the situation. So next slide, please. So there was a large MDT. I won't go through everybody who was involved, but as you can see from the slide there were a lot of staff members from every area. So obviously Northamptonshire Healthcare NHS Foundation Trust, who were responsible for Natalie's care while she was in Berrywood. Northampton's Children's Trust became involved because of the unborn baby, and adult social care obviously had a role to play. And then, of course, the Northampton General Hospital, because of we were responsible for administering antenatal care to Natalie, and ultimately she was coming to us to birth her baby. So we, all of us together, needed to create put plans in place to make sure her needs were met. I'm just going to open it up. Would anybody have any ideas of what sort of plans would need to be put in place to provide care for Natalie? If you would like to raise your hand if you've got any ideas. Next slide then, please. Oh, sorry, Debbie Wigley.
Hi Joe, it's Vicky. I'm behind here.
Oh,
I think
hi, Vicky.
I think hello. You can sort of see me lingering. I think the consideration for both Natalie as the person and the unborn, I think that makes this really difficult in terms of a situation that you haven't just got one to think about and what's best for both of them at that time. I think that must have been really emotionally difficult for everybody involved.
Absolutely, yeah, that's quite right, Vicky. There are, you know, a number of needs that needed to be met and factors that needed to be considered. So there were a number of plans all running at the same time, and to try and coordinate that to ensure that, you know, every aspect was covered and there wasn't anything being missed and everyone was up to speed with what each other's areas were doing. So multidisciplinary team planning and meetings were really integral to ensuring that this ran as smoothly as possible. So the plan. Oh, hi Emma, thank you.
Hi Joe, sorry, I was just thinking about the impact on the staff as well. You must have really needed to plan for both the staff from the hospital that she was coming from and into yourselves, and sort of take into account the emotions that were going to be involved for the staff that were going to have to care for Natalie when she came in to birth the baby.
Absolutely, and I think as part of that sort of MDT planning, I think we very much looked at, as I said, putting robust plans in around Natalie, the unborn baby, her mental health, the birth planning, and when we go on to I'll look at later in the presentation on areas to improve. I think one of the things that really came out was that that dissemination of that information round to all the staff that were providing the care was something that maybe we didn't give enough thought to in that process, and actually as an area of improvement in future, I think that's something that would need a lot more work ongoing. So the plan, thank you for those questions. So the plans that had to be in place, we had to have a perinatal mental health plan, obviously because of the fluctuating nature of Natalie's mental health and the impact of her pregnancy on that. That obviously things like her medication would need to be altered as a pregnancy progressed, so that was reviewed regularly. Restraint was something that needed to be used at times for Natalie due to her violence and aggression. So obviously the consideration for the unborn baby, a pregnant lady, and what that meant. So that needed looking at very closely. We needed a clear obstetric plan, so Natalie's birth plan. So it was really important that we, although Natalie's mental health, as I said, was extremely fluctuating and at times deteriorated significantly, it was really important that we made every effort to ensure that her needs and wishes were heard, considered and planned for. We also needed to apply to the Court of Protection for an anticipatory order, and basically that meant that in the event that Natalie lacked capacity to make decisions for herself and her unborn baby, in the best interest of herself and her unborn baby, should I say, that we would have the jurisdiction to intervene and make decisions on her behalf in the best interest of herself and her baby. And then obviously not forgetting that the unborn baby and the child protection plan and what was required in order to ensure that that baby was safe when born. The local authorities plan was to obtain an interim care order in the event that Natalie was too unwell to care for baby herself. The next slide, please. sorry, just to go back there, and with the social care plan, there was obviously there was a liaison with the police as well in the event that, as I said, Natalie was too unwell, that we would need to apply for a police protection order when baby was born, whilst we were waiting for a care order to be granted. So during Natalie's pregnancy, towards the end, she was reporting reduced fetal movements. However, there was an inconsistency in the reporting of the reduced fetal movements, which is the biggest indicator for us in obstetrics and maternity of fetal well-being. Because of Natalie's paranoia and delusion, she felt that members of the staff who were part of the tribe, were working with John and Jim to ultimately remove her baby from her. So she became very suspicious and had shared that she would not report basically around the baby's well-being. She wouldn't tell us whether baby was moving or not. And staff were really, really anxious within Berrywood, understandably, that she may birth at Berrywood without the support of midwives or obstetricians, and that was something they were really concerned about. So because of those concerns, the plan then was to admit Natalie to Northampton General and plan around an induction of labour. Natalie was really, really adamant that historically she had had 3 normal pregnancies, 3 normal vaginal deliveries, and she really did not want a caesarean section. So the plan, in line with her wishes, was to do everything that we could to ensure that she had a normal vaginal delivery. And on the face of it, from the obstetric picture, there was no reason why we couldn't achieve that. So that was the aim. We made a plan in the unit. So the normal procedure for induction of labour would be for women to be admitted to the maternity observation ward. They would be in a bay of with 4 beds, other women present, and start the process of induction of labour. Obviously, because of Natalie's mental health, that wasn't an appropriate plan for her. So what we arranged to do was use what was usually our bereavement suite, which is a self-contained area on labour ward, so that Natalie could be in there privately. She had a 3-to-1 support from staff from Berrywood, so they could all be in that area together. It's a room, it has its own bathroom facilities, it has its own fenced off courtyard area. So the plan was that we would have Natalie in there and she would be in the sort of most comfortable environment for her. She had a lot of paranoia and concerns around males in particular. So we wanted to avoid the potential of coming into contact with male visitors. And obviously, because of her violence and aggression, she did pose a potential risk to patients, their visitors, and potentially members of the public. So, and then labour ward is a very busy ward environment, and obviously very different to her placement in Berrywood. So the plan was that she came into us and we administered her care and started that plan for induction on the Snowdrop suite. Unfortunately, as a best plans always, we thought, well, we've thought of everything here and this is going to be, the best environment for Natalie. But unfortunately, that fed into her delusional beliefs. She was concerned that she couldn't hear babies crying, she couldn't hear other women in labour. She didn't necessarily feel that she was on the labour ward suite. The courtyard garden that we'd used for Natalie, so that she was a smoker, so that she could go out and smoke and be safe. She believed that John and Jim would be climbing over the fence to get her. So actually, although we'd made a plan that we thought would make her more settled and calm in our area. In some ways that began to work against us. So, as I said, her mental health began to deteriorate. She assaulted her obstetric consultant. But we worked very closely with the staff from Berrywood. We had a team of designated staff that she trusted, that were with her around the clock, and they worked very hard. They worked extra shifts, wanted to be on call for when she came in. So eventually Natalie did settle, and we thought things were going really very well. Went home one evening, came back, and she'd had a really bad night. As I said, the paranoia and delusions had increased. She was suspicious of midwives. There were real challenges in the midwives in having to provide care, because she wouldn't consent to monitoring of baby. So it was really difficult for us to have a clear picture of what was happening with this baby. She wouldn't give consent for a vaginal examination, which is another very significant and important part of an induction of labour. So the plan that we had to try to facilitate a normal vaginal delivery was looking sort of more and more fragile. Natalie had become, she was making threats to staff. And so, as Emma said as well, that really made staff very uncomfortable, very fearful of maternity workers, and midwives are not necessarily used to caring for patients with significant mental health issues. So whereas if you work in a mental health environment, you would be more familiar with this kind of behaviour and not so frightened by it. For staff on the labour ward, it was quite challenging, and also they were in a position where they were unable to give the care that they would ordinarily, and so their anxieties around the well-being of Natalie's baby increased. So because the picture was changing, we were having regular meetings during the admission just to review our plan and see where we were going with things. Unfortunately, Natalie then was no longer wanting to engage with the staff that were caring for her, the 3-to-1 staff support that she had, and she was refusing to take her medication. So her psychosis was increasing. And in the end, unfortunately, staff were unable to be in the room with her because of the fear of violence and aggression and concerns around that. So we were in a situation where we had Natalie in a room. We had a obstetric plan that we weren't able to fulfil. We also had the corridor where the room was situated. We had bays of pregnant ladies, their visitors. And a situation where we were unsure if we were able to contain Natalie in the room that she was in for much longer. Could I have the next slide, please? So an urgent MDT was called, and with consultation from the perinatal team, consultant psychiatrist, everyone, obstetrician, everybody involved, the decision was made a very difficult decision was made to perform a caesarean section, and this would have had to be done under restraint. So it wasn't a decision that was taken lightly, but it was becoming untenable for us to keep everybody safe, keep Natalie safe. As I said, we had no idea about baby's well-being, and we had to, also consider the safety of other patients in the area and the staff providing care. So From that point, we ensured that the area was cleared completely. We asked all patients and visitors to remain in their rooms, not to come out unless they had call belled. So the staff were there to go and respond to those bells, but not to move around the unit in the normal way. We went into theatre. There were about 20 people from the MDT team within theatre, and we had a roundtable discussion where we talked through every step of the journey in terms of the how we were going to perform this very unusual. In fact, I think everybody involved had never been involved in this sort of decision and this planning before. So every individual in the theatre talked through their role, what they were going to do, and we basically walked through the how we were going to approach Natalie, explain to her what was happening, perform the restraint if needed, and transfer into theatre, and then perform a caesarean section under a general anaesthetic. I have to say that this was done with the utmost care and dignity. It was a really emotional moment for the staff involved. As I said, nobody entered into that lightly, and everybody acted with the highest of compassion and just ensuring that Natalie's dignity and privacy were maintained at all times. So even to the point, and sorry, it always makes me a little bit choked, but when she was restrained, the care and compassion that the restraint team, because I think those words of restraint to a pregnant lady about to have a caesarean section, it conjures up some really sort of negative images. However, as I said, it was done in the most gentle and compassionate way. So baby was born via caesarean section, a beautiful baby girl. She was fit and well, which was, you know, a huge relief to everyone. And then, as we had anticipated, that Natalie was too unwell to care for her baby, baby was then transferred to our neonatal unit under a police protection order. And an emergency hearing was requested for the care order to be applied to baby. Any questions at all from anyone, just as I'm rattling through?
I was just going to ask you, was Natalie quite calm, or was she being aggressive when she knew what was going to happen?
To be honest, I think that in the build up to the decision, she was becoming aggressive. And I think there was, because the way Natalie controlled her environment historically was around pinpointing certain members of staff, as you know, especially in Berrywood setting, so that she had around her a team of people that she had selected. And I think that was kind of her way of controlling her environment. Initially, as she came into us, she exhibited those behaviours again. I think obviously that transfer into our unit, and then she, as I said, she settled. But then I think as the picture sort of, as things were evolving, I think Natalie somehow knew that she was losing control of the situation. Yeah. So she then began to, you know, those behaviours around pinpointing staff, people becoming part of the tribe, that increased. And what that meant was that the 3-to-1 ratio of staff that could provide her with care was reduced. So it no longer became safe. Interestingly, and as you've said, when the decision was made and the restraint team went in to talk to her and explain what was happening, she at that point was quite calm. She did require some mild sedation, but she didn't. You know, we were anticipating that she may well fight and resist, but actually she didn't. And I think, you know, it's tantamount to the excellent work that the restraint team do, the therapeutic way that they deliver it was, you know, absolutely amazing. And I think when we talked about it, because they wear body cameras, obviously I've never worked with a restraint team before, and they said, actually, you know, the cameras are there for, you know, to record for training purposes, but also for the patients to feel safe, because they know what's being done to them is being recorded, and that actually usually once they're at that point, they tend to comply with what's being asked of them. Does that answer your question?
Yeah, that's fine. Thank you.
Thank you. Anyone else? So was that Debbie that asked that question? Sorry.
Hi Joe, it's not a question, but it's really a comment about how difficult it must have been from the midwifery team and the obstetric team to see a lady about to be taken for a cesarean and to be restrained, because that isn't normal, is it? And we're always in the caring environment, so that must have been extremely difficult for everybody involved and other observers as well.
Absolutely, Debbie. I think the thing for midwifery is, midwifery means with woman, midwife, and it is about making sure that, as a midwife especially, and even the obstetrician that was involved is very much pro women's choice, and making sure that every avenue is explored to get, what ultimately we want. And the really sad thing about this was that Natalie's delusions were around her being sort of held down, cut open, and her baby removed. And so although it was the safest thing that needed to happen, it fed into that delusion, really. So that, for us, it was a real challenge. We were doing something that she really had told us that she didn't want to happen. So yeah, it was a real challenge to staff, Debbie. Yeah, exactly. Thank you. Next slide, please.
Sorry, just before we move on, there's a question in the chat from Carlos, and he says, had a mother and baby psychiatric unit been considered?
Yes, thank you, Carlos. That's a very, very good question. Yes, it had, as part of the planning from the perinatal mental health team and the consultant psychiatrist. However, because of her mental health prognosis, sorry, I don't know if I said that at the beginning, her prognosis was that it was unlikely that she was ever going to make a full recovery. Each admission that Natalie had, her mental health had deteriorated more significantly each time. So there had been consideration made. However, she was too unwell at that point to be appropriate to go to a mother and baby psychiatric setting. That answer your question? I hope so. Sorry, I can't see the chat.
It does. It does. Thank you.
Yeah, thank you. Okay, next slide, please.
There's just been another question in the chat. Did she have any family member present at birth, if she had any?
Unfortunately, she didn't, and that was another sad, really sad part of this story, is that Natalie didn't have anyone as a family or friend, really, anyone else to support. But what I would say is that what became apparent when we had a debrief, which I'll come on to later, is that the people around her, the people providing care, especially the staff at Verywood, had almost become her family. As Debbie said, it was others have said as well. So a lot of emotion around this, because from a mental health perspective, staff that was supported Natalie had been through her journey with her pregnancy with her. She was she had bonded with her baby. She had named her baby. She had made preparations. She was very worried about the prospect of her baby being removed from her care. So that was a real conflicting sort of viewpoint from staff, because staff really thought, well, she should be given an opportunity to sort of fulfill her role as a mother. However, it was this situation as it was deemed that she was too unwell to, although that's what she very much wanted. Natalie was so unwell that she wouldn't be in a position to care for her baby. And although she'd never made any suggestion that she would harm her baby, she was very adamant that if she had her baby, no one would be removing or taking a baby from her. So as I said, the decision was made for baby to transfer to the neonatal unit after birth, and then under that police protection order. Could I have the next slide, please? So once the cesarean had been performed, Natalie then went into a side room and was cared for by a midwife, and back to the 3-to-1 support from the Berrywood staff. Unfortunately, again, mental health prognosis was, the mental health deteriorated further. She became again very aggressive towards the staff that were caring for her, pinpointing certain members. So this reducing team was reducing even further. She mobilised very, very quickly, which is often the case with women that smoke. They want to get up and get out and have a cigarette. So she was up and about. She could hear because she was on the labour ward, which was the most appropriate place for her to be cared for post-surgery. But she could hear other babies crying, so she was making threats to other babies and other women. Why would they? Could they have their baby and she couldn't? We had taken pictures for her of her baby up on the neonatal unit and kept giving her regular updates. She did ask to see baby, and that again was very, very difficult. Not to allow that, and that decision wasn't made in isolation by Northampton General Hospital. That was a decision, again, we had another MDT meeting that day with the psychiatrist, social care, and sought advice from the police, because obviously the baby was under the police protection order, and all professionals agreed that it was too risky for Natalie to have any contact with baby. Which again, as a midwife, is the hardest thing. I've never been involved in anything where any case where a mother hasn't not had care or spent time with her baby, when she has wanted to. Sometimes women don't want to. However, that was a real challenge. We ensured that all the baby was dressed in clothes that Natalie had selected, that baby had been given cuddly toys and the blankets, and we'd taken pictures of those. We also offered to have a FaceTime call with baby on the ward, but Natalie declined this. And I think as well, because she was so unwell and so poorly at that time, her interest in the baby waned quite quickly, and she had paranoia and delusions around Dom and Jim being with the baby. They'd held the baby, so she didn't want to hold the baby at that point. So that we quickly, as soon as we could, transferred her back to the original bereavement suite, so she could be in that contained area, so that she wasn't having to go through the ward, and, as we said, listen to the sort of babies crying and experience the distress of that and become more agitated. But as I said,
can I interrupt a minute?
Yes, of course.
Why on earth? I know, I would have thought midwives are not the only people that could have cared for her after the birth. So why did you allow her to almost stay and hear all of the noises around her? That must have been really traumatic for her. Could you not have taken her somewhere else after the birth? Why keep her in that environment that would be very distressing?
She was in that environment for the minimum of time. So during the night, she had had a general anaesthetic. She'd had major abdominal surgery, so she needed to be in an area. And again, the room we use, so we usually have a transitional suite. You come from theatre, you go into a 4-bedded area. We didn't take her in there. You need a one-to-one care with a midwife, so she had a side room right next to the transitional area. Because she needed that, as I said, regular observations and one-to-one care with the midwife. Where she was experiencing, at least, going through the labour ward, when she was up mobilising and going to have a cigarette. So it was that point we then moved her into the contained area that she'd been in before, so she could still, be up, have a cigarette, and be with her, the staff that were providing the care for her. So as soon as she was able to, sorry, what I'm trying to explain is, as soon as she was able to be stepped down from that one-to-one post-surgery care, we moved her. So it wasn't a long, prolonged period. As I said, it was sort of overnight while she was recovering from the general anaesthetic and for a few hours in the morning. Again, because she was so unwell, we had another MDT meeting, and the decision was then made for her to transfer to, she wasn't even going to go back to Berrywood where she was, but she needed to go to an intensive care bed at that point. So she transferred out to there. Does that answer your question?
Yes, it does. Yes
Yeah.
and no.
I know.
But I wasn't part of it. I wasn't there, so you know it's quite easy to be sort of judgmental, if you know what I mean. Yeah, if you're not in that scenario, yeah.
It's a very emotive subject, and
it
for
is.
everybody involved. And yeah, but you know, every effort was made to minimize that, not just because of the distress that would be causing to Natalie, but also the safety of everyone else, because obviously the more agitation and upset she was getting, the more difficult it was to manage the situation safely. So every effort was made to, you know, to try and minimize that upset to her. Sorry, I think, oh, Emma, you've got your hand up.
Yeah, Jo, I was just going to say, I suppose at that time also the amount of time that she spent on the ward, you know, you've got to get that baby out safely as well, haven't you? So absolutely. The maternity unit had to be their best place for her. Yeah. At that time.
Absolutely. And I think that's the thing. We were grappling with so many different elements here. So the safest place for her to have her baby, the safest place for her at that point and her baby was a maternity unit, a labour ward. But it was the most inappropriate environment for her mental health diagnosis and where she was in that. So really and truly, before she came to us, when we went back and reviewed, she should have been in an intensive care bed then. However, they kept her at Berrywood and managed her there because they knew her well there, they knew the plan, they knew what was happening, but it was the most inappropriate place for her to be. So it's just about trying to balance that and manage those multiple things that are all going on at the same time, really, as safely as possible. So as soon as possible, there was an arrangement was made for secure transport to the intensive care bed. The restraint team came back to NGH, and at this point, so we did worry that again there might be that Natalie would resist and you know be sort of fight the fact that she needed to be moved, but actually that we may need to sedate her and use restraint. But actually the ward manager came from who she was very close to and well trusted. She came and she spoke to Natalie. She explained what was happening, and Natalie quite happily got up, went with her, and she walked and she left the ward. So we planned for the eventuality that she would resist and it would be difficult, but in actual fact I think she was quite resigned to the fact that she was you know, she needed to go somewhere else, and she did go. Again, we just made sure, which was a challenge, that all of the areas that from the exit from the snowdrop suite she was in, the labour ward reception, were clear, so there was no one there. No one wanted to make sure that her privacy and dignity was maintained throughout. And the staff were just absolutely brilliant. Secure transport team, the restraint team, again, I can't praise them enough for how well they cared for Natalie, and in an environment that they're not usually, they're not used to working in. So it was a real testament to everyone involved. Okay, thank you. Next slide, please.
Just before we move on, we've got another question in the chat from Selena. Any mention of the baby dad at all?
No, we didn't know who the father of the baby was. obviously somebody, you know, from that Natalie encountered on the ward leave. Natalie, whilst she was an inpatient at Berrywood, did pinpoint another patient and said and believed that he was the father of the baby. He wasn't, but even that became problematic, and he had to be moved to another ward because of this sort of delusional belief and sort of the intensified, it was detrimental to his mental health well-being, so he eventually had to be moved out of the area. Okay. So things that were really, really good, I think, about this and management of this case was that there was really good, robust care planning by all services. And as I said, we were all, you know, regular meetings. Everyone involved was aware of where everyone else was at. The application to the Court of Protection was done in a really timely manner. Often there can be criticism to maternity services and obstetrics that these are done sort of very much last minute, but this was done with, as I said, all of Natalie's thoughts and wishes were carefully considered and had been explored, and that was part of gaining that anticipatory order. So there was a compliment made about that from the Court of Protection. The other good thing, I think, was that making sure that we had those meetings regularly whilst we were sort of executing that plan, because so, you know, you can have all the plans in the world written as well as you like, but actually following those through and what that looks like in real time can sometimes be very different to you know, what you've planned for, what the reality is. That MDT working on NGH site, as I mentioned before, everyone was you know, brought their best game in an area that they were really not used to working in, so that was a fantastic piece of work as well. And then following the once Natalie had been transferred out and settled in her intensive care, but there was an MDT debrief. This, I think, was particularly useful for the staff at Berrywood, who had a lot of emotion and upset around what had happened, and I think also it gave a real opportunity to explain that child protection process around them and around to them, because I think there was a sort of a lack of understanding around that because they were, you know, not experienced in working in that. So and also I think the perspective from maternity, sharing our thoughts and feelings about how difficult and challenging it was for us as professionals to do something that is really, you know, the opposite of what we want to do. Just be having that sort of that debrief between services was really, really useful. Well, it was for me anyway, so I hope it was for the other staff that were involved. I think areas to improve, like I said before, I think there could have been better collaboration within maternity itself. Berrywood had got a designated team around Natalie. We attempted to have that within maternity services, so to have staff around her that will you know, aware of the history, the picture, to have a little bit more of an understanding, I think would have made it easier when trying to administer that care in that, and you know, when she came in for the induction. Unfortunately, due to staffing capacity, it wasn't something that was possible at that time. So in future, you know, that's something that we would really like to look at internally. And I think an improved dissemination of that information from that MDT down to the people who are actually providing the care, you know, so they could have a greater understanding of all the different processes that are involved, different elements of it, and you know, the needs of that unborn baby, and to, you know, to keeping that baby safe, which I don't think necessarily was paramount. Because Natalie was their patient and that Natalie was their concerns. It was more Natalie's thoughts and wishes and those not being able to be fulfilled that was very distressing. But obviously, from a safeguarding perspective, the safety of the unborn baby was also paramount. Thank you. Next slide, please. So in summary, good MDT working and I've piece in here, sorry, devising robust care plans with regular meetings to review planning and real-time execution of the plan, ensured a good outcome ultimately for both mother and baby in extremely challenging and emotional circumstances. And although every attempt was made to execute Natalie's thoughts and wishes, sadly, due to her fluctuating mental health and the increasing level of risk posed, it was not possible to meet those wishes. But despite this, I do truly believe that Natalie and her baby received an excellent level of care. And that sound MDT working meant that Natalie and her baby and patients and staff were kept safe. So, next slide, please. Thank you. And any more questions? Hello, Suzanne Binley.
Hi, Jo.
Hi.
Hi. I just wanted to say thank you so much for sharing. You know, clearly it was a very emotive case for everybody involved, but I think you've been able to articulate the kind of the amount of care and respect that was given to Natalie. So hats off to you all, actually. No, thank you so much. Yeah.
Thank you. Thank you, Suzanne. And actually, when we had the psychologist who held the debrief, we went to Berrywood and had the debrief. One of the things that will always touch me is there were a number of, you know, I think there was about 40 people in the room, and he said that although Natalie's journey was a very, very sad one, actually the amount of care and the sort of almost like the family that had been created around her, the people, was probably the most she's ever had in her life. Yeah. So that people could take some comfort from that. So thank you.
Yeah, that's good. Do we know how Natalie is now?
I don't know. I'm afraid. I know that she did transfer from the intensive care bed, so she did become well enough to move out there. But yeah. I don't know. I did actually today when I was running through the presentation, I did think I would like to know where she is at the moment in her journey. Yeah.
No, thanks for sharing, Jo.
Thank you. Hello, and we've got is it Lewis? Lewis, hello.
Hello. Oh, sorry. It's basically my name's Crystal Franklin, and Lewis is my son, and I've logged on his by mistake, but I haven't got a question. I clicked on something by mistake.
Oh, okay. Thank you.
Sorry about that.
That's okay. Thank you.
Thank you.
Hi, Debbie.
Hi, Jo, me again. Just to say thank you for sharing this case. And I work within the safeguarding team, so I saw the emotional impact it had on everybody, including Jo and the safeguarding midwives. And this is the reality in midwifery, I think now across all services, but particularly midwifery, seeing more and more patients with mental health issues. And I'm a learning disability nurse, so I know that we see more and more parents with learning disability, different levels of learning disability. So our midwives have had to work in a whole new different way. But the most touching thing for me in this case is that despite Natalie's challenges, people saw the person beyond those extreme challenges, and there was no evidence of diagnostic overshadowing or no discriminatory practices. So it's really refreshing, but can't underestimate the amount of hard work and collaboration it took between all involved.
Thank you, Debbie. Yeah, I think, like you said, we are seeing a real increase in complexity of need and yeah, increased mental health issues, and I think it's something that is only going to increase, you know, with the current issues that we've got, and it's just about, you know, learning from these cases and just trying to just do the best that we can, and just like you say, remembering that the individual at the centre of this. So yeah, thank you.
There are a couple of comments and questions in the chat. So the first one is, did Natalie have the support of an independent mental health advocate? Yes, she did, and I'm sorry I forgot to mention that, but yes, she did. Yeah, so for all of it, the process, so for the Court of Protection,
because Natalie had to be represented at that, so she had advocacy for that, and also in the child protection process as well. So yeah, she did have an advocate. I'll add that to my presentation for future. Thank you for the reminder.
Thank you. The next one is, you've answered how Natalie is. Do you know how the baby is now?
Unfortunately, I don't get sort of regular updates or feedback. I do know that you know, baby was extremely well, because there was a concern. Obviously, there'd been substance misuse during pregnancy. Obviously, we hadn't got a full picture in that antenatal period of how well baby was doing. But yeah, she was a beautiful baby girl, a good size. So yeah, but no, I don't, I'm afraid.
Thank you. And then there's just 2 observations. So the first one is, this is a good case to argue for midwife-led mental health care where they have mental health skills, maybe counselling intervention to be implemented in their skill set to ensure positive outcomes. And then the second is, you should all be proud of the care and treatment Natalie received.
Thank you. She did have I don't go in the MDT. She did have a specialist perinatal mental health midwife that was providing care in the antenatal period. But absolutely, I think there needs to be you know, it's an area of improvement in terms of staff coming into contact, you know, in those acute settings with patients with complex mental health needs. Definitely is an area of improvement. Thank you. Thank you very much, everybody. Is there any more questions at all? Okay, well, thank you everyone for listening. It was my first time ever of presenting on MS Teams, so I hope it was okay. But yeah, thank you everybody.
Yeah,
thank you.
Thank you.
Thank
Bye.
you.
Thanks,
Bye.
Jo.
Thanks, bye.
Thank you.
Thank you. Bye. Bye.
Thank you.
Thank you.
Jo,
Hello.
is there a